Hi, this is Ian Wright. Sorry about the change of time. I kind of got myself double booked. I'm not very good at kind of coordinating different things. I actually had a list of patients who I was doing later this afternoon and forgot completely that I was meant to be talking and lecturing at this time, but most people see this later anyway, so it's probably me talking to myself into my phone, as I seem to spend a lot of my time at the moment doing. So I'm spending a lot of time doing remote healing, and suddenly I have this big remote healing practice, really busy, and I'm now even teaching colleagues doing 3-way Zooms where I'm showing a colleague how to do remote healing with a patient. It's a very interesting, fascinating process to have this kind of long lever, this long view, and sometimes the precision is exceptional. And I think once we have to get over this kind of spatial and temporal limitations in our perception, and then this whole world opens out in this, and it's something that I've really been developing over this time. It's been an opportune thing for that. Anyway, it's a whole nother story, and I could do a 10-part course in that, but I'll do that at another time. Let's talk about prematurity, actually. I want to talk about the potential of, and if people have heard me lecturing, I often start with talking about the real potential for what we do. And you see these most incredible things that happen in the Daisy Clinic in Ireland, or the Paediatric clinic that I sometimes teach at in Italy or in London. And there's incredible stories that unfold working with complex genetic disorders, complex neurodevelopmental disorders, cerebral palsy, autistic spectrum disorder, even to working, as I'm going to talk about here today, working in hospitals with premature babies or incredibly sick children and the real incredible potential for what we can do clinically. And we just, I think, need to sharpen our tools, sharpen our clinical skills, sharpen our perceptual skills, and it becomes an incredibly rewarding and exciting process, and watching the potential for health unfolding in these children who have incredible compromise, be it from genetic threads, be it from trauma around birth, be it subtle neurodevelopmental issues that come through. And, our job is really unlocking this huge potential which is ever present in children. And it's a great actual honor to be working with them. And today, I think I'm going to talk about prematurity, because it's a wonderful, wonderful area to consider when you're teaching this subject, because it affects every system in the body. Every system is either immature or potentially damaged, and it's an incredible learning experience to work with these children, and everyone should be in there and working. And part of the reason why I give this lecture and why I teach this and why I'm doing this, I will be doing this online teaching, is that in all hospitals, I believe there should be people like us working to unleash on the potential of these children, because the clinical effects are always, and I've been doing this for 30 years and teaching it for over 25, the clinical effects are potentially so incredible, so wonderful, actually. And so I just want to talk, first of all, about a very interesting kind of learning experience that about 25 years ago, I'd say, maybe slightly more, I'd led a team working for the Children's Clinic in London into Great Ormond Street, into the neonatal ICU. And I think there's a team of three of us, and we were in there and working with this premature baby who was tiny. I think at the time maybe 26 weeks, and then I'll talk about the timings later on because it's kind of an important thing how actually the working with premature babies has changed for when I was first practicing. 26 weeks it would be something, and now 23, 22, 21, it's incredible how the changes in actually the medicine has brought along the number one, the survival rates, number two, the potential for care in these children, and it's a fascinating subject. Anyway, it's a wonderful learning experience for understanding intention. So when we're working in this kind of way, it's very subtle, it's very delicate. And I always teach this fine line between intention, which is where you intend to do something to the tissues, and attention, which is wider. And our most effect is when we draw back our intention and we allow our attention to be wider. Now, the interesting thing is, you're gloved up through and your hands are close and touching a newborn baby in the incubator. And premature babies are wonderful teachers because as soon as the intention went in, with one of the students, the alarm bells would ring up, the respiratory, the pulse, the alarms would go crazy and everyone would freak off and come back. And it was a stunning thing of allowing yourself to not be too intentional, but allow yourself to have a broad attentional awareness and support the potential unfolding in that moment of that neonate, but a neonate who's still really a fetus. And it's a wonderful unfolding. And because every system is involved, you could just do if you were going to teach, say, pediatrics, you could just do prematurity as one lesson. And that lesson would bring in everything: the cardiovascular system, developmentally, the gastrointestinal system, the urinary tract infection, blood and the development of blood, the biliary system, the respiratory system, the neurodevelopmental system. But that lecture would last 3 weeks. It's a huge thing. So right here, we're just going to do a little bit of an introduction just to keep your brains going, and we'll see where it takes us because I can't cover everything, So prematurity is really, that's a broad term for neonates that are born before 37 weeks. So it's the most common cause of neonatal death, mortality. If they're born with less than, I'll talk about low birth weight in a minute, less than 1,000 grams, there are 3 main causes for mortality: respiratory failure, infection, which is to do with immaturity in the immune system, or congenital malformations, organic, central nervous system, musculoskeletal. So physical examination is the most common way of diagnosing because you can never be sure of maternal dates. 20% of mothers are unsure of their last menstrual date. So they use the Ballard score of working out the prematurity of a baby, which is to do with the ear cartilage. So less than 30 weeks, there is a small amount of ear cartilage, and there is a reduced or flattened pinna. Also, they look at the feet. Before 33 weeks, there's only an anterior, not a posterior foot crease. Breast tissue is another way of looking. So pre-28 weeks, there's no breast tissue, and you can barely see the areolae. The genitalia are underdeveloped. So gestational age of 28 to 34 weeks is confirmed normally by findings of regressed vascularity in the capsule of the eye. So premature newborns have a huge amount of physiological challenges, which we're going to just cover briefly, when they're trying to adapt outside this perfect, warm environment, which is the uterus. So when we talk about the development of the central nervous system, the development of the cardiovascular system and the respiratory system, these are huge subjects. So we won't talk about it in this. So if you imagine a baby who is born at 21 to 23 weeks, what hasn't developed yet is huge. So, for example, the fetus has this potentially rich, highly nutritious supply of oxygen, waste transport, and nutrition through the placenta. It lives in this warm, finely controlled, fluid environment. And suddenly, for reasons we'll cover, is exposed to the harsh, cold, lack of fluid and has to breathe with lungs that are immature, working through a cardiovascular system and nervous systems which are underdeveloped. This is a major challenge. Before birth, the placenta has 4 major roles. Number 1, provision of nutrients for growth. 2, elimination of waste products. For example, heat, carbon dioxide, urea, bilirubin, which are transferred across the placenta and eliminated by the maternal excretory organs, for example, the liver, the lungs, the kidneys, and the skin. The placenta also provides for a synthesis of hormones that regulate fetal growth. It also acts as a barrier to infection using mucosal macrophages. So, from 32 to 34 weeks, IgG and other immunoglobulins start to get transferred to the fetus, and any placental dysfunction reduces this progress. Before 32 weeks, the preemie baby can be severely immunocompromised. So antibacterial activity, the amniotic fluid has a huge antibacterial effect, and that improves as the gestational age increases. Maternal circulation contains much more substances than the fetal, for example, glucose. The placenta is metabolically active and consumes glucose. So every organ in a preemie baby is immature and has functional limitations. So the job in a neonatal ICU is to monitor and regulate the specific needs of each organ system until they reach some kind of functional maturity. This is, of course, where what we do is so important, because working, the way we can work, one of our modes of action is to engage with these formative embryonic forces that can fundamentally affect the rate and strength of maturization and functionality of the whole. And so we can engage with each system within the whole, which is either immature or has been damaged. This is vital. So again, we need to be working in these, I say this in all these lectures, working in these intensive care units and start supporting this natural unfolding. Very important. So, etiology of prematurity. This is normally due to a variety of factors that can induce a preterm or labour or a rupture of the membranes, or due to maternal issues, for example, hypertension or preeclampsia or diabetes, etc. One cause, chorioamnionitis. This is inflammation of the fetal membranes, the amnion and the chorion, and it's due to bacterial infection. This is normally an infection that ascends from the vagina, often from a vaginal examination. It's normally accompanied by fever, fetal tachycardia, uterine tenderness. This is a very common cause of premature labour. There are a variety of other vaginal, maternal, and fetal infections that can induce early labour. Another cause can be intrauterine growth restriction. This is defined as a baby that's below the 10th centile in weight. So there are two types of this, asymmetrical. So 70% have weight length restricted, head is normal, head is normally 3 times the weight of the liver. Here it's 5 to 6 times, it's much bigger. Usually growth is normal in the first 2 trimesters, but in the third it starts to restrict. There's normally a chronic raised blood pressure, which creates a malnutrition from placental insufficiency, or there are other genetic factors, for example, Ehlers-Danlos syndrome. There's a symmetrical intrauterine growth restriction, which is due to a global growth slow rate. This is usually due to an early maternal infection or drug, alcohol, misuse, heroin, etc. Chromosomal abnormalities can cause this, or marked anemias. They can cause that as well, this growth restriction. Diabetes. Just over 20% of insulin-dependent diabetes have preterm labours. Preeclampsia, high blood pressure and proteinuria, this usually begins at around 20 weeks. Risks of that, obesity, previous high blood pressure, diabetes, can be linked to abnormal placental development and abnormal natural killer response in the fetus, more frequent actually in the first pregnancy. This produces, of course, impaired blood supply to the placenta fetus and distress. Another cause, multiple gestation. So preterm births occur, which means before, say, 35 weeks, because actually often twins, etc., are born around 36 to 38 weeks anyways, even if they're C-section. But that occurs, preterm, which is classified as pre-35, occurs in about 25% of twins and increasingly in triplets. So again, as you get older, you're more likely to have a preterm baby. If the mother is too young, there is an increased risk of prematurity, and if you're over 40. Tobacco usage, 30% of preemie deliveries, actually, the mother smokes. And that's increased if she smokes marijuana. Stress, extreme stress, not normal, everyone's stressed, but can cause premature labour. Trauma, falls, accidents can cause it. Placental insufficiency from infection, etc., can cause premature labour. Placenta previa, another cause of it. IVF, some increase as well. Subfertility, which is often associated with gynecological issues and poor blood supply to the uterus, are risks. That's a whole big subject which I like to talk about. Women with either weak or short cervixes are more likely to have preterm births. Celiac disease and other autoimmune conditions are more likely to have early deliveries. Untreated yeast infections can have greater risk. Periodontal infections, gum infections, have been linked. So have appendicitis, pyelonephritis, kidney. Interestingly, less connection with viral infections. So in all, about 12% of babies are born preemie. There are 4 mechanisms that happen. One is maternal or fetal distress. So that's an activation of either the maternal or the fetal hypothalamic pituitary adrenal axis. Often, birth is triggered actually by fetal HPA activity. Second mechanism is inflammation. Decidual, which is the uterine wall. Chorioamniotic, which are in the fluids around the baby, or systemic inflammation in the mother. Or hemorrhage around the uterus, or abruption, or some sort of pathological uterine distension issue. But prematurity, which is temporal, must be differentially diagnosed from extremely low birth weight, ELBW, and from other factors. ELBW, sounds like a cricket game, doesn't it, is an infant that is born less than 1,000 grams. This is most commonly linked to fetal growth restriction if it's not a preterm labour. Other factors are blood pressure, infection, placental insufficiency, genetic factors, drugs like we talked about. So vaginal bleeds, membrane rupture and fluid loss and contractions with cervical dilatation are all signs of early labour. Various factors can reduce incidence of this, from managing infections, managing blood pressure, managing diabetes, or taking progesterone, or suturing the cervix. So specific risks for a preterm baby. This is a huge subject and we could literally spend 3 weeks on it. Every system is affected in major and minor ways. Every physiological cycle, protein, enzyme, valve, blood vessel, capillary bed, alveolar bud, organ, muscle function, tone, bone, membrane, cerebrospinal fluid, everything is affected. It's huge. So, let's name some key areas. Neurological issues, retinopathies of prematurity, hypoxic ischemic reactions, periventricular leukomalacia, interventricular hemorrhages, etc., etc. These are, it's a big subject in terms of the potential effects neurologically, and that's 3 lectures. More subtly, neurodevelopmental delays, which can be linked to poor thyroid function in preemie babies, but subtle wiring issues, because myelination, synapses forming all occur later on in the pregnancy. For example, the development of the cerebellum happens, a lot of it happens, it's one of the last parts of the nervous system to myelinate and to develop in terms of neurogenesis and synaptic connection and wiring. And a lot of it happens actually after 35 weeks. And so if you haven't had that perfect environment for the development of the final development of the cerebellum, you get prone to DCD, developmental dyspraxia type patterns, and mild coordinational issues and subtler, more specific learning difficulties. Again, each of these subjects is a lecture, and beautiful, because actually how we can access them is the most exciting part of what we do. Because actually the reason for this is, how can we, doing our job, access these? And this is the great and exciting bit, because we can access all of these areas. So cardiovascular issues, there are problems with the development of the capillary bed. It's unfinished. Often there's a failure of the ductus arteriosus to close, PDA, patent ductus. Respiratory issues, and I'm going to talk about respiratory distress syndrome because it's huge in a minute. But there's lack of alveolar development and, of course, lack of surfactant, and they're key issues and fundamental. Gastrointestinal and metabolic issues, neonatal hypoglycemia, feeding difficulties, which is a huge subject for us in terms of the development, the final development of the cranial nerves. In terms of the 9th, 10th, 11th and 12th, it's especially affecting tongue function, valve function, gastrointestinal function, immaturity of the function of the gastrointestinal system, immature gut biome, immature digestive, enzyme function, tongue, palate dysfunction, cranial, esophageal muscle and function and weakness. And actually an important part also is hernias and necrotizing enterocolitis, but also there are primary vascular issues, because I think it's the gut and the brain that are prone to a lack of perfusion in placental insufficiency areas, and that's a huge, because there's actually vascular necrosis in local areas of the gut, and that could be why that child is hugely colic, etc., strong gastric problems. So there's so much here. Hematological immaturity can lead to anemia in prematurity, thrombocytopenia, hyperbilirubinemia, jaundice, immature immune function, tendency to infection, sepsis, pneumonias, UTIs are real problems. And one of the first things that needs to be controlled is temperature control due to immature thalamic and hypothalamic function. It's immature, and so there is poor temperature regulation. So how is it managed? Well, in labs, they need to check blood glucose for hypoglycemia, blood counts for anemia, white blood cells, high or low white blood cells, immaturity of the neutrophils, infection, blood type with antibody incompatibilities with mother. And then they have to keep a very tight management on serum electrolytes, sodium, potassium, calcium, glucose, vital to manage unstable electrolytes. Imaging they need to do with the heart, the lungs, cranial ultrasonography if, for example, there are unpicked up bleeds. Lumbar puncture is routinely performed, and you know what lumbar puncture does as it pierces the dura, locking down the dural globe. It's a very important thing for us to look at and support, but it's important for them to get blood cultures. So, management, in classic terms of management, first thing that needs to be managed is respiration. So the earlier the preterm is, the more likely there'll be respiratory distress syndrome, IRDS, or surfactant deficiency disorder. This is caused by developmental insufficiency of surfactant and structural immaturity of the lungs, most often in preterm infants. And this is the leading cause of death in preemies. So surfactant appears in the cytoplasm around 20 weeks. It's present in about 50% by 26, 28 weeks, 25% by 30 to 31, more frequently if the mother is diabetic. Symptoms appear shortly after birth of surfactant insufficiency, which is fast breathing, tachycardia, expirational grunting, and turning blue. This can lead to respiratory failure, which is increased blood, carbon dioxide, and prolonged apnea. Surfactant is a complex system of lipids, fats, proteins, glycoproteins, and it's produced by type 2 pneumocytes and packaged into lamellar bodies into each cell. These bodies unfold into a lining around the airspace. This clever material reduces the surface tension of the fluid that lines the airspace. Surface tension creates 2/3 of the elastic recoil in the alveoli. This works like a bubble contracting, giving the smallest surface area and keeping the same volume. This causes the airspace to contract, reducing the surface tension. The surfactant stops the airspaces from completely collapsing on exhalation, and also allows the airspace to enlarge more easily on inhalation. This is compliance. So without it, the lungs tend to collapse. But this, combined with decreased alveolar development, local immune insufficiencies, and poor segmentation of the nervous system, leads to lung distress. So respiration needs to be stabilized as quickly as possible. The goal is to maintain optimum lung volume. This is achieved by early CPAP, continuous positive airway pressure, given nasally usually, or extubation with an endotracheal tube, and mechanical ventilation. The dangers with that treatment are hyperoxia and hypoxia, so oxygen is monitored at all times, the alarms. Also, barotrauma and volume trauma, meaning too much pressure or too much volume can damage the lung fields further. So different centres focus on either CPAP or mechanical ventilation with differing results. Research is varied for them actually and depends on the skill of each team. Nasal trauma rate in CPAP is about 55%, but in mechanically extubated infant is 39.5%. So surfactant needs to be administered within 2 hours. If you're continually forcing open lung spaces when you have a raised surface tension, you're going to damage future elastic recoil of the lungs. Respiratory distress syndrome is usually a 3-day issue. Most are stabilized by day 2, but it's still the major cause of death in a baby. So the assisted breathing and surfactant therapy is usually backed up by a course of corticosteroids, which are important, but of course already weaken an immature kidney function. So what do these lungs feel like? These feel like flat-packed lungs. There's a huge pressure of forced volume and pressure on them. There's a lack of recoil. There's a lack of alveoli development. There's an increased immune response, and bronchial-associated lymphoid tissue increases in its development, which is immunotissue, lymphoid tissue, which normally is formed as a response. It's more common in babies and young children. There's a lack of sense of fluidity in the whole, but very specifically on the alveolar surfaces. So this is one huge area where we can be very, very helpful in multitude of ways. I'll talk about a little bit that at the end. Number 2, thermoregulation. So newborns lose heat. Newborns lose heat in 4 different ways. Evaporation. Internal heat is evaporated through the fluids on the surface. So it's really important to keep the newborn preemie baby completely dry, or they will lose too much heat. Conduction. So the baby must not be put onto cold examination tables, scales, etc., or they will lose too much heat through conduction. Convection, which is loss of warmth air next to the skin, so they need to be covered, wraps, incubators, etc. Radiation, so if it's too cold outside, they will lose it to the room. And so the temperature in these neonatal ICUs needs to be over 25 degrees. So preterm infants can't compensate as we do for cold stress. They've relatively tiny amounts of subcutaneous fat, and the thermoregulation of the thalamic nuclei are underdeveloped. Preterm infants cannot shiver as term babies can. The increased surface area to body mass ratio means there is more surface area to lose heat, especially in their relatively large heads. If an infant's cold, it puts huge metabolic and respiratory stress. They go into distress, and they put their systems, they're already under stress systems, under more pressure. So it's key. The warmth, skin is a very important area when you're dealing with preemie babies. The immaturity of the skin can manifest in the following. So there's a decreased or absent stratum corneum, which is the outer protective layer, which is normally composed of 15 to 20 layers of dead, flattened cells, which acts as a protection from infection and dehydration. There's a decreased cohesiveness between the layers of the skin. There's an increased water loss and a sense of swelling and edema. Bathing is with no soaps, no disinfectants, no adhesives. Before they're 30 weeks, babies need to be in this high humidity incubator or a room with over 70% humidity, or they risk water loss through the skin. Also, fluid and electrolytes need management. So because of that transdermal through the skin water loss and their immature kidney function, fluid and electrolytes need constantly monitoring. Initial fluid is normally glucose water mix with a little bit of calcium added later. In normal term infants, the loss of extracellular water in the first few days is about 5% of the birth weight. But in preemies and extremely low birth weight infants, it can be up to 20%, which is dangerous. So diet and feeding, as we know, preemies less than 35 weeks have poor coordination of suck and swallow reflexes and decreased intestinal motility. So nutrition in the first few days is normally given intravenously. Initial nourishment is ideally colostrum because this contains digestible proteins, IgA, growth factors and cofactors which promote the growth of intestinal villi, especially for preemies, and influence the gut biome. Normally, mature breast milk replaces that transitional milk by about 10 to 12 days. In breast milk, most calories are contained in lactose, which is about 35%, and fat, 50%. Preemie babies have poor lactase production, so can have great difficulty in digesting lactose. Calcium, potassium, sodium, and trace minerals are often not enough in breast milk, and they're often added. But osteopenia, lack of calcium, remains a problem in prematurity in both breast and formula-fed babies, as there is poor, and there can be poor mineralization of teeth. So just talking about kangaroo care. Kangaroo care is currently being used at a global rate of about 1%. There is a big push by the World Health Organization for this to be 50% by 2020. They say that this would save an estimated 500,000 newborns worldwide every year. So kangaroo care is a group of practices around the care of preterm infants that makes total sense. It was developed in the 1970s from watching kangaroos and marsupials. It includes skin-to-skin contact, mother, father, or caregiver, warmth, reduced heat loss, skin development, and a loss of transdermal losses in terms of heat and fluids. So you have a baby wrapped around you in literally in a swaddling cloth, skin to skin. You're both naked on the tummy, and the baby is right next to you. So you have this natural heat, this natural fluidity, this natural fluency. It mimics as much as possible the intrauterine environment. It's beautiful. Helps with bonding, oxytocin pathways, helps actually with parental confidence, development of the gut biome. So the baby just wears a small nappy and it's wrapped tightly and the skin is stimulated. So you're getting the sensory skin stimulation, which helps the development and synaptic formulation. The baby's carried very close. Bonding movement, the movement, so every time mother or father, whoever the caregiver is moving, that movement gives you that vestibular stimulation, which has a definite and clear effect on neurodevelopment. Auditory stimulation, the voice, the heartbeat, is ideally, the heartbeat stabilizes actually very fast when they are very close to the mother. It's very easy and connects with breastfeeding. That's a whole massive series of lectures. Colostrum importance, etc., etc. The aim is to achieve exclusive breastfeeding, which has its oxytocin, bonding, confidence, gut biome, neurodevelopmental, so many different factors that, we could talk about that all day. So this idea of kangaroo discharge, so the mother and the preemie baby are discharged out of a hospital environment early, but they stay within this kind of confine of the baby is stuck to mum the whole time. This could have a huge effect in the developing world, if it's really, but it makes total sense. And the research in preemies, the most important thing is that it normalizes temperature. It normalizes heart rate, respiration. There's fewer infections, quicker weight gain, improves sleep patterns, increases cognitive development, decreases cortisol levels, reduces the pain response, the pain sensitization, the shock, increases motor development, reduces colic, increases bonding, etc., etc., etc. It's the obvious solution, and it's just not done enough. So, what can we do as osteopaths? I mean, when I started this, the reason for this is there is so much we can do. There are so many systems. How do we work on this? What do we look at when we're treating these babies? If we start with the idea of this fetal embryo starting from a conceptus, which is this totipotent whole, this field of wholeness. And from this field of wholeness, movement perfect movement unfolds, and movement creates form. And this movement, which is creating form, is this wholeness unfolding and expressing itself. And that expresses itself in every organ system, in every hormonal system, in musculoskeletal system, in the gut, the central nervous system, the heart. Everything is unfolding within this wholeness. And if there are many different ways of engaging this and treating this, but there are key kind of factors that I would look at, and one of them is potency. Potency is a kind of sense of power within an expression of health, and that can be on a cellular level, or it can be on a visceral level as a whole, or it can be within the whole. Often potency is compromised in preemie babies because they've been through shock, trauma. There's a lack of expression. So in our work, we're looking at expression. So allowing potency to express itself. Ignition, this light, this sense of ignition in the tissues, which sparks everything into proper expression. And that's vital from a cellular level to the whole, to the function of the third ventricle. But expression in terms of engaging with the perfect unfolding of these formative fields, these biokinetic fields, these actual fields of motion that you can feel that are remnant in the baby. This is a beautiful way of working with preemie babies. So, for example, you can look at the part which could be seen as a cellular memory or a field of function. So the heart starts as it begins with a metabolic gradient of oxygenation that happens in the tissues, and it starts as a pooling, and at the same time, blood starts to form in these pools. And as the blood is forming, the forming of the fluid motion of the forming blood produces little riverways, canalization, canals, and from the fluid riverways, canals, that forms tubes, and the tubes are formed around the motion. And then the tubes undergo a series of movements as the relative descent of the heart occurs with the lifting of the cranium. There is a descent and a rotation and a folding of the heart, and it creates this perfect form, the four chambers of the heart. And it comes in to the midline, which forms its septi. And this embryonic biokinetic field of motion is available for us to feel and engage with and allow its full expression. And that is, you can do this with every single part of the body. Every part has this remnant biokinetic motion within its formative field. For example, just to give a couple of examples, there is a dilation field biokinetically, which is mesenchyme which is no external forces are opposing it, like the formation of the heart, this opening. This creates the muscles, which creates the peripheral diaphragm, the heart. For example, a suction field, which is a loosening field where pockets of membranes get sucked into tissues with watery fluid. And this is how the lung fields form and the liver forms. Or a detraction field, a field of plates being pulled apart over each other, which is the ribs. Or contusion, forces being pushed against one another, which forms cartilage in the sternum. Retention fields, where mesenchyme is stretched against an opposing force, and that creates fibrous tissue, like the central tendon of the diaphragm. So every tissue, every limb bud, every organ has biokinetic motion, a remnant of these formative fields of motion, and we can engage and support support that expression, and none better than in an unfolding premature baby that's trying to grow and express itself. And, you know, if you just take the central nervous system in terms of its potential development, with all the synaptic wiring that is occurring, the myelination processes, that a lot are happening after birth, a lot of happening right towards the end of the delivery. So our potential use and our potential usefulness when treating these preemie babies is huge in supporting this unfolding of the whole. And because of this incredible potential plasticity, which is inherent within the nervous system and actually within all systems, because it's still growing, any small areas of damage are available to us. So suddenly we've got this incredible ability to do huge amounts of things. And this brings me back to the potential for what we do. If we can really get very precise with what we're feeling, what we're working with our hands, and really understand what's trying to happen here and learn to support it in a very precise way, it's incredible, the potential for what we do. And, you know, of course, I'm a huge fan. And if you've heard me lecture before, I'm always talking about this wonder, you know, this is why we want to share this information, for us to learn this, because we can all learn how to do this. You know, if we have the right clinical background and the right learning tools, our skill base can be huge, and we can access and treat incredibly complex situations, even things that you wouldn't imagine. If you visited my practice, you'd be amazed at the amount of different, incredibly complex things that we treat on a day-to-day level, we engage with, and you can help with. I mean, you know, this isn't a miracle, but we can support and maximize potential, and that's our job, is absolutely maximizing the potential health and expression within these preemie babies. So that's why preemie babies is the best lecture, but this lecture would go on for 3 weeks if we actually went through every system and how every organ functions embryologically, and how it's trying to continue that embryonic function into growth, and what is compromising it, and how to overcome that. And that's where we start to really get into the intricate detail of what we're doing. Anyway, that's a little bit of an introduction there. The next lecture I'm going to give, it actually isn't really going to be a lecture, but it's on the 29th of June, and I'm going to do it again I think I should do it at 4 again, because I have patients in the evening, so and I won't have time. And this time I'm going to talk about, the next time I'm actually just going to talk about this thing I've been working on, and I've been working on for quite a long period of time. And it's new, and it's different, and it's this kind of international pediatric certificate that I've been working on. Now, we've been teaching the diploma in paediatrics in Ireland since 2009, but we're just looking at ways to access and to teach this in a different kind of format. And I've been working on this for a long period of time, but I'm able right now to actually finish off this work, and it's a whole new kind of learning experience. And it's a 3-part course, and the courses, say part 1, I'll talk about this in great detail next time, but the first part is we're going to talk about care of the neonate, care in pregnancy, some detailed embryological stuff. And it's split in part 1, split into, say, 13 or 14 chapters. Each chapter is like a lecture. And then it's a 2-part practical. And the practicals are split into 1 part. 1 part, we're going to be doing stuff which is to do with our own development, which is to do with engaging with stillness, neutral, the tide, all these kind of things, ignitions, and all that kind of side of things, basics that we have to have an experienced embodied knowledge in ourselves to get to. And then the second part is practical stuff, teaching all those kind of golden nuggets of incredible detail, how to treat, ASD, or how to treat reflux, all the very, very complex kind of specific detailed things. So this is a kind of, there is nothing better than working in clinic with groups of patients together with people and learning together. That is the best, and that's what we run at the Daisy Clinic, and it's wonderful. But there's a huge amount of embodied knowledge that needs to be taken in, and so I kind of put together this audio. It's all audio. It's 20, 30 hours plus in each course of audio on all the specifics, so you can kind of get to know the specifics. Anyway, that's what I'm going to be talking about on the 29th. I'll probably talk for 45 minutes about that course and what actually is part of it and how it becomes a certificate and how to do learning and case studies, etc., and interviews with the teaching team and all that kind of stuff. There's a lot of detail in it, and I'll talk about that next time for anyone who's interested. But the purpose is to share, and because we need everyone doing this. Anyways, I know that's just an introduction. There's so much to talk about with it, but it's something I certainly will get back to on the course. I wish you well, and I'll speak to you soon.